Morning, everyone. Today, very important topic will be this topic. TMS team will take care, and for this, I request Dr. Joyita to introduce the speaker as well as moderator because they are from TMS team and Dr. Joyita knows them very well. So we'll listen about them, both of them, regard their speaker and moderator, and then very important topic, opioid and immune system. It's very important to understand what exactly in this topic is and how we should be taking care of. Dr. Joyita, please go ahead.
Thank you, ma'am, so much. Good morning, Sushma, ma'am, and good morning, all our friends in the IAPC Online Series 6. It is my pleasure to introduce our speaker and moderator today. The speaker is Dr. Kashish Vats. She is our junior resident, third year MD Palliative Medicine resident in Department of Palliative Medicine in Tata Memorial Hospital. As you can see, Dr. Kashish, her interest lies in ICU palliative care, and she is quite a punctual and very particular person. And it is a pleasure to say that she is extracurricular. I think she is a fabulous artist and she draws really well. She's very creative. So thank you, Kashish, for doing this particular topic. Our moderator is Dr. Sachin Gunde. He is MD Palliative Medicine. He passed this year, and he is now currently a senior resident in Department of Palliative Medicine in Tata Memorial Hospital. A very sincere worker. Sachin's interest lies in home care, and he's currently looking after the home care team in the department, and he is going to moderate this particular session. So I hand over to you, Kashish, and to you, Sachin. Thank you.
Thank you. Thank you, ma'am. Is my screen visible?
Yes.
Okay.
Yes. Yeah.
Shall I start, ma'am?
Yes, please.
Okay. Good morning, everyone. I'm Dr. Kashish Vats. I'm a third-year resident in Department of Palliative Medicine at Tata Memorial Hospital. And today's topic is opioids and the immune system, friend or foe. So opioids are the mainstay for management of post-surgery pain, acute and chronic pain in cancer, as well as non-cancer settings. As with all drugs, opioids also elicit a range of undesired consequences, including affecting the functioning of the immune system. They're also the illicit drugs of abuse, have capacity to influence anti-tumor immunity, have potential immunosuppressive effects, and a connection between prolonged opioid administration and increased susceptibility to bacterial infection has been suspected since the late 1800s. Now, coming to the overview of the immune system. So these are the common cells and the types of immunity we'll be discussing further in the upcoming slides. So an overview of that. So the first types of cells that are seen in the immune system is the dendritic cells. Their role is antigen presentation to the major histocompatibility complex classes 1 and 2, and they are part of the innate immunity. Then there's natural killer cells, which have anti-tumor and antiviral activity, and they are cytotoxic. Then neutrophils are antibacterial, antifungal, same with macrophages. CD4 plus T cells have immune coordination and regulation. Then CD8 plus T cells have cytotoxicity, and B cells are antibody producers. Now, coming to the function of innate immune system, so it recruits immune cells to the sites of infection through production of cytokines and chemokines. It activates the complement cascade to promote the clearance of antibody complexes. Then there's activation of adaptive immune system through a process known as antigen presentation. Then they act as physical and chemical barrier to infectious agents. Then the functions of the adaptive immune system includes they have a more differentiated reaction to pathogens. It involves T and B lymphocytes and their products, and they create memory after an initial response, which enhances subsequent response when encountered with that particular antigen. Now, analgesia by endogenous opioids from the immune system. So, this is a diagram of endogenous opioid peptides released from the immune cells of the innate and the adaptive immune system. So neutrophils and macrophages and T cells, they migrate into inflamed tissue in response to chemokines. And then the release of opioid peptides is triggered by cytokines, chemokines, and bacterial products. And opioid peptides, they bind to opioid receptors expressed on the peripheral sensory neurons, and the cascade this causes peripheral antinociception. Then the mRNA of beta endorphins and proenkephalins are to be found in found to be expressed by blood splenic cells, lymphocytes, and macrophages. Then anti-inflammatory macrophages generate and release opioid peptides in inflammatory and neuropathic pain, which is mediated by toll-like receptors 4, signaling in vitro and in vivo. In vitro, M2 polarized macrophages contain and release more endogenous opioids than other macrophages types. So M2 is a polarized type of macrophages. Then in vivo, the adoptive transfer of M2 macrophages leads to a reduction in mechanical but not heat-induced hyperalgesia in neuropathy. Again, then when stimulated with mycobacteria in vitro, only neutrophils release metenkephalins and beta endorphins, which is again dependent on intracellular calcium mobilization and PI3K activation, and also activation of formyl peptide receptors, but not toll-like receptors in vitro and in vivo. The naive CD4 plus and CD8 plus T cells, they produce and release opioid peptides at inflammatory site only after the activation and proliferation into their respective specialized phenotypes. The anti-nociceptive effect is mediated by mu and delta receptors on the sensory neurons in peripheral and the central nervous system. Now coming to the impact of opioids on the immune system. The first and the most commonly studied drug is morphine. And this is the overview of the effect it has on innate immunity and adaptive immunity. So in innate immunity, it affects macrophages, neutrophils, mast cells, natural killer cells, dendritic cells, and intestinal barrier. And adaptive immunity, it reduces T cell, B cell proliferation and increases T cell death and Th2 differentiation. And it all leads to decrease in pathogen clearance. Now, first we'll read the effect on impact on innate immune system. So on innate immune system, morphine reduces the number of macrophages by decreasing the proliferative capacity of macrophages, progenitor cells, and lymphocytes. Then it inhibits the recruitment of these cells into the tissue. Then activation of mu receptor, it triggers the phosphorylation and desensitization of chemokine receptors on macrophages, leading to this receptor insensitivity. Then again, chronic morphine use inhibits the ability of macrophages to phagocytose, which again reduces the clearance of pathogens. Now this effect, it is dose dependent. Lower to moderate doses can only impair phagocytosis. Then higher doses lead to morphine-induced apoptosis via toll-like receptor 9 and P38 MAPK pathway. The findings have shown that there are two mRNAs, MIR 582 5P and MIR 590 5P, that target CAMP response element binding protein 1 and 5, that is CREB 1 and 5, which is decreased in monocytes from heroin abusers compared with monocytes from healthy controls. Then this downregulation of both the mRNAs leading to decreased CREB 1 and 5, it reduces N5 kappa B phosphorylation and TNF alpha levels in monocytes. Now, selective opioids decrease neutrophil bactericidal function by inhibiting the production of superoxides. Then morphine inhibits mast cell activation via a negative crosstalk between opioid receptors and the toll-like receptor 4 signaling pathways. Fentanyl administration to male Swiss Webster mice inhibits lipopolysaccharide-induced TNF alpha production in intraperitoneal mast cells. Repeated administration leads to a loss of immunosuppressive effect and sensitization of LPS-induced TNF alpha secretion. This effect is characteristic solely for fentanyl. Now, coming to the impact on adaptive immune system. In adaptive immune system, it impairs T cell function, then attenuates T cell proliferation. It alters the expression of cytokines, suppresses T cell apoptosis, and modifies T cell differentiation, as well as reduces B cell function. Then activation of mu receptors result in superactivation of adenyl cyclase and increase in intracellular CAMP, which further initiates downregulation of major histocompatibility complex 2 cells, especially on B cells. Now, opioid-induced mucosal barrier impairment and microbe composition. So, chronic morphine use has been shown to impair the barrier function of gut epithelial cells. So it does by disruption of tight junction proteins that is mediated by activation of toll-like receptor 2 and 4 by the mu receptor agonist. As a result, there is translocation of E. coli in the mesenteric lymph node and liver tissue in of mice, and on increased dosage of morphine. Then again, chronic morphine treatment, it also alters the gut microbacterial composition and induces preferential expansion of gram-positive pathogens and reduces bile deconjugating strains of the bacteria. Then the peripheral and the central mechanisms of opioid-induced immunosuppression. So there's two types of effects. The acute effect, so there is activation of sympathetic nervous system, which innervates the lymphoid organs like spleen. Then on acute administration, it enhances the activity in the periaqueductal gray, which again activates the sympathetic nervous system. And it induces the release of biological amines which suppress splenic lymphocyte proliferation and NK cell cytotoxicity. Then in nucleus and then there is also in chronic effect, there is prolonged use of opioids, there is increased hypothalamic pituitary adrenal axis activity, and it causes glucose corticoid production, which again decreases NK cell cytotoxicity. If given before the development of cancer, morphine has no effect on cancer growth, whereas morphine increases the progression of established cancer and decreased survival by interaction with tumor mu receptors. Now, immunomodulative effect as per the opioid type. Now, this is a table of different opioids with effect on animal cell studies and human studies done in vitro and in vivo. We'll be discussing the same further. So, duration and type of opioid administration leads to differential effects on immune system. The literature reports that morphine and fentanyl decreases NK cell toxicity. Buprenorphine, hydromorphone, and codeine do not have NK cell cytotoxicity, and tramadol enhances it. The first drug we'll be discussing is fentanyl. So in preclinical studies, that is the animal studies, fentanyl, it induces a dose-related immunosuppression. Then in rodents, if continuous infusion suppresses NK cell activity, lymphocyte proliferation, and cytokine production. Like morphine, fentanyl significantly inhibits lipopolysaccharide-induced TNF production by macrophages at the same doses at which it produces anti-nociceptive effects. In human studies, it affects cellular immune responses and cytokine production.
Dr. Kashish, hello. You're muted, I think, by
Kashish,
mistake.
hello.
We can't hear you.
Huh. Kashish, I think it's mute. You have to unmute yourself.
Yes, sir. Now am I audible?
Yes.
Yes.
So till where did you hear? So
You can start with the human studies in fentanyl.
okay. So in human studies, fentanyl has been shown to affect cellular immune responses and cytokine production in patients and healthy volunteers in a dose-related fashion. So at higher doses, that is 70 to 100 microgram per kg, and intermediate doses, that is 23 to 30 micrograms per kg doses, there's significantly depression in levels of pro-inflammatory cytokines, that is interleukin 1 and 6, compared to patients who receive lower doses. In healthy volunteers, studies, the acute intravenous fentanyl injections increased NK cell cytotoxicity, probably due to an increase in the production of NK cells in the circulation rather than an increase in the cytotoxicity. Next drug is methadone. So in older animal studies, it has shown that chronic methadone treatment in rats did not affect either trichinella nor listeria infections. Then methadone is actually administered in a racemic mixture with R-methadone possessing opioid receptor agonist activity, and the S enantiomer, that is not having any analgesic efficacy. It causes the greater inhibition of lymphoproliferation. Then in human studies, in vitro, methadone did not influence any monocyte and neutrophil phagocytosis, but in vitro, it increases the production of T helper cell 2 cytokine interleukin 4 through transcription factors. Then in a randomized control trial that reported that the switch to methadone or buprenorphine restored the immune function depressed by heroin in the addicts. Moreover, a controlled methadone or buprenorphine therapy also normalized the helper cells balance that was significantly unbalanced in chronic heroin use. Then coming to oxycodone, in preclinical studies, it expressed weaker immunomodulatory properties compared to morphine. And in a one single study that was conducted in vitro with mouse splenocytes, an inhibitory effect of oxycodone was reported on lymphoproliferation. Then human studies, then oxycodone does not influence monocyte and neutrophil phagocytosis nor NK cell activity, but it decreased interleukin 6 production by T lymphocytes. For ramifentanil in preclinical studies, it has shown to suppress immune response characterized by a significant reduction of NK cell cytotoxicity, lymphocyte proliferation, and cytokine secretion. In another rat study, ramifentanil infusion also significantly reduced activation and cytokine production from bronchoalveolar neutrophils and macrophages in lipopolysaccharide-induced lung injury. In human studies, in vitro, if ramifentanil is added to human neutrophils from healthy volunteers, it induced a dose-dependent reduction of pro-inflammatory cytokine production not seen at lower doses. In another study in patients undergoing a coronary artery bypass graft, ramifentanil suppressed mainly pro-inflammatory cytokines such as interleukin 6, TNF, and interferon gamma, but did not significantly affect the anti-inflammatory cytokine, that is interleukin 10. Coming to buprenorphine, in preclinical studies, in a study in rats, after acute injection of equianalgesic doses of buprenorphine and morphine into the mesencephalic periaqueductal gray, buprenorphine did not alter NK cell cytotoxicity, T cell and macrophage function, In a model of surgery, stress in the rat, buprenorphine prevented all the biochemical, endocrine, and immune modifications caused by the pain. Human studies, in recent studies, it has shown that the ability of buprenorphine to reduce CCL2 induce chemotaxis and transmigration into the brain of subclass of monocytes. The CD14 plus and the CD16 plus monocytes that play an important role in HIV sustained neuroinflammation in AIDS patients. Then discussing tramadol. So in preclinical studies, tramadol did not induce any immunosuppressive effect either after acute or chronic treatment. In the animal studies using specific antagonists, it was demonstrated that immunostimulating activity of tramadol has to be ascribed to its serotonergic activity. In human studies and in vitro studies, tramadol did not affect human polymorphonuclear activity from healthy volunteers. Patients treated with tramadol at equianalgesic doses with morphine showed a faster and a full recovery of immune parameters depressed during surgery. Now, a double-edged sword of using opioids and the COVID-19. So, coronavirus directly infect macrophages and disrupt T cell antiviral response by stimulating the T cell apoptosis, thereby disrupting the immune system. Furthermore, immune suppression caused by opioids may facilitate the entrance of virus into the body and have adverse effects that may increase comorbidities. But recent studies have shown that inflammatory cascade and cytokine storm syndromes are evident in some phases of this disease. The high concentration of cytokines leading to hyperinflammatory syndrome may lead to multi-organ failure and death. So immune suppression, which decelerates the inflammatory process, might play a protective role in some COVID-19 patients. Now, various opioids in chronic use appear to have different effects in suppressing the immune system and modulating the cytokine release. Depending on the type of opioid and the chronicity of the use, people with opioid use disorder may respond differently to infection with COVID-19 at different phases of the disease. However, epidemiological evidence so far available indicates a higher susceptibility of patients with opioid use disorder in contracting COVID-19 disease and having more severe and detrimental effects. Now, effects of opioid tolerance and withdrawal on the immune system. So, interestingly, some parameters of immune function demonstrate tolerance, whereas the others do not. So, B cell proliferation to anti-IgM and interleukin-4 stimulation was normal in tolerant animals and cytotoxic T cell activity. But the ability of spleen cells to produce interleukin 2 or 4 when stimulated with anti-CD3 remained suppressed, as did the NK cell activity. So there was an observation made in 1993 that both NK cell activity and CD4 and CD8 plus T cell ratios were suppressed in monkeys who were given daily morphine injections for 2 years. This led to the conclusion that tolerance did not develop in these immune parameters. Then most immune parameters tested are suppressed following drug withdrawal. So recovery time to baseline response levels varies in different studies. In a single report of withdrawal in humans, immune function was suppressed for up to 3 years. Then there's underlying sepsis combined with morphine-induced hypofunction of the hypothalamic pituitary adrenal axis, maybe occult variables modulating immune responses during opioid administration and withdrawal. As episodes of withdrawal are common among drug abusers, more intensive investigation is warranted. In a nutshell, in vitro studies and animal models cannot provide conclusive evidence for opioids' impact on the human immune system. These results should be interpreted with caution due to different methods used to measure the functionality of the immune system, the variability of the dose used, and the small number of participants in the study available. Currently, it is not possible to provide clear guidelines for how to handle different scenarios in clinical practice. Each substance seems to have a different effect. Further studies in specific subpopulations, such as immunocompromised and critically ill patients should also be investigated. Thank you.
Sachin, you want to say something?
Yes, ma'am. There are no questions in the chat box. So when we try to search for this particular topic, so particularly if we speak about the human studies, so we came across those two studies. That one was by Dublin et al. And other was Visettle. So with taken both the studies in conclusion, there is hardly any relevant evidence in patients, and there is lack of concrete RCTs here in the clinical endpoints. Um, if we study the drugs in the particular patient setting, then there are no studies who have determined what is the effect of long-term opioid therapy on the rate of developing infections and ultimate patient mortality. Like in the studies by Dublin et al., they studies the community acquired pneumonia in older adult patients, and they found that the opioid users were at a higher risk of developing infections. And as we spoke about the study of the Visettle, they did the study in the patients with rheumatoid arthritis. That is a non-cancer study. And they studied the same patient over the course of the disease. And these rheumatoid arthritis patients, when they used the opioids for the purpose of pain management, in those particular periods of opioid use, they were found to have increased risk of infection and hospitalization as compared to the periods when they used some non-opioid drug for their pain management. So here we are saying there is definite role of these opioid drugs in modulating the immunity, even in the same patients when they are used for the same purpose at the different time points. They have caused the increased risk of immunosuppression and infections, developing the infections. However, still contracting these two studies, there is a 2015 study by Hosner et al. In a non-cancer setting. They found there was no increase in the incidence of infections in patients who received the opioid drugs for long term. So there are very contrasting evidences. And if we go into the details why these results are contrasting, to see that, we may find that all these are basic science research, and there are very less studies in the patients. So it depends on the which opioids we are testing, which component of the immune system we are testing. Like in this particular seminar, we saw that immune system, in particular immune system also, there are different components of the immune system which are differently affected by the opioid use. So if we see at some cases the proliferation of the B cells is being affected, and in some cases some parameters like the interleukins and they are getting stimulated. So it is very conflicting to say that the same immune system and different parameters, and they are getting affected differently by the opioid use. Again, third is the administration schedule. So different studies have used different methods. Like some studies have utilized while if we speak about some in vitro studies, they have used morphine pellets to see the effect of these opioids on the particular cells, how they behave under the effects of opioids, like a 75 mg morphine pellets in the petri dish. And if we speak, for example, of the opioid withdrawal studies, they have used the naloxone also, for that matter, to study the effect of it on the development of this behavior of this particular immune cells in the on how these particular cells behave under the influence of withdrawal. So, and also the experimental models differ. say some at some point of time they use mice, at some point of time they have used monkeys. So that genetic polymorphism also plays a role, and we should not forget that. And so in a particular model, when we try to establish this studies, so the interpretation should be done in that context, because at some point of time, if we still think of extrapolating the results to the humans, there will be some pharmacogenomics which still may be playing role in the human studies. Also, here I want to stress on a particular point that all these studies have been referred to the molecule morphine. So they have taken morphine as a reference molecule, and then they have gone ahead. So Kashish spoke about the thing about the anti-cancer immunity. So see, pain is basically immunosuppressive. So we will come to this sentence in the end again. Meanwhile, I speak about something about the surgeries. So post-cancer surgeries, what these opioid drugs, they are particularly used for the purpose of pain management. But it has been found that post-surgery, in the patients in whom we have used these opioids for pain management, like remifentanil or fentanyl, or even morphine for that purpose, the, uh, the post-surgery incidence of metastasis or the recurrence of the cancer, such incidents have been found to be increased in case of because of the opioid use. So that is one of the thing that is to be keep in mind. But if we speak about the palliative care patients, many of the times they are referred to us in the later phase of the disease. So we have such a kind of population, we don't which they come to us at a point where they have very lesser amount of period of time. Unfortunately, they still have to live. So here I want to say that analgesia is important, particularly for the palliative care patients. And if we keep in mind, we do not exactly know about what is the duration that because of the opioid use, these patients are going to develop the next malignancy. We do not know. Unfortunately, they will live for that particular period or not. So it is better to give the analgesia as of current evidence stands. We can say that it is better to manage their pain. So at least the quality of life is, we can hope for a good quality of life if we suppress their pain. I go to
Thank you.
some
Sorry.
of the
I
chats.
just can I just come back to this point, Sachin
Yes, ma'am.
and Kashish. Sorry for asking a few questions. Is that I think it should be clear that it is not clear. So it is a very
Yes, ma'am.
complicated situation. And I think the take-home messages that I have are that, that there is that effect of opioids on immune function, one. Second is, this effect is not a class effect. It depends on the particular opioid type, which both
Yes.
Kashish has demonstrated. Thirdly, is that there are more preclinical studies, as has to be, because this is what we are looking at, and human studies, whatever evidence, is still not very equivocal. But despite that, we know that morphine has a different effect to fentanyl. And because in our palliative care daily practice, our ambit of patients has really increased, isn't it? It is not just best supportive care patients that we see. We are referred patients for complex pain management in post-surgery and surgeries in metastatic disease. So we do that. And hence, I think we have to think about the implication of it in clinical practice, as to at least be aware of it. Because as you said, Sachin, that one important thing is about expected survival and where in the trajectory that we are coming in. So
Yes.
for me, I think we have, of course, we three are sitting in an oncology setting, but most of our audience is also doing non-oncology every day. So that is why I think we need to differentiate between cancer, non-cancer, and some population that we don't see, but we might overlap, they might come to us, are the opioid use disorders. So I think we have to be very mindful of this particular topic in these three groups of patients. And in cancer, of course, because we see so much of early palliative care these days, and so many patients on immunotherapy, and so many patients that we do see in the post-surgical phase. So it will be important. And I think that study that you mentioned, and it was about morphine, isn't it? That it was associated with decreased survival, more risk of infections, more hospitalizations. There was that recent study about that. So hence, for clinical practice, we need to be mindful of that. And because we have been seeing in our practice so many years that we are following our patients, so all the more this makes more sort of sense to me. And the second important thing apart from clinical practice is that there's so much possibility in now basic science research, because this is coming into our domain. So whatever we do has to influence our practice, and hence there is so much of potential for basic science research. So I think it's a very difficult topic, Kashish, and you've done a very good presentation and taken a lot of effort under the guidance of Sachin, and that might explain it. Is we are all learning from you, so that might explain the lack of questions at this point. So we're still grappling with so much that you have given, but thank you very much, and over to others for asking any questions. And sorry, Sachin, you still had to say something. Sorry.
No, not particularly, but the research recommendation that appears here is even at some laboratories, if we are conducting the basic science research. So if we are studying, for example, there about the say B cell production, about the chemotaxis, then we should also try to correlate the same with the clinical endpoints. Like in that study, we saw about the mortality or the rates at which the infections are developed and the subsequent hospitalizations. So these endpoints should be, if they are correlated, then we can get the research with the strong evidence. So as at present, it is quite unclear, but this may generate a good evidence base for the further research on this.
Thank you. And for people who would be referring to Kashish's presentation, she has given the references at the bottom of the slides, and those are very important papers that she has. So for the more details, please do check into those papers. There are nice review articles that she has referred to, and the details are there in the slides. Please do so.
Thank you, Joyita. Thank you very much. Thank you, Kashish. I know this was a tough topic for you, but after listening all the throughout the lecture, I realized that there is a huge need of doing research in this area in our own group of patients, especially the patient those who are in true end stage of the disease, plus the patient those we are treating as a non-malignant disease patient, and we are using opioids on those patients. So I think there is a huge potential to do research in our own group, because whatever results we have from outside country, I think there are so many things different in our patient population, and we should try to do. Now there are so many MDs and DNBs are going on all over country. I think they should one of the guides should pick up this topic, and they should do the research so that we will have our own data. So thank you very much. It was such a wonderful presentation by a junior most palliative care physician of this, maybe third year resident, but for us, I think she is just becoming a palliative care physician. She's going to become palliative care physician in a year or so. So thank you very much, Kashish. Thank you, Vats, and thank you, Joyita. And thank you everyone for joining.